It's my great honor to welcome my dear colleagues for the next panel, Internet of Things in Healthcare, the Dawn of New Revolution. It's a great honor to welcome Dr. Claus Jensen, who is the Chief Digital Officer at the Cancer Center. Great thanks for he's behind all this major production that we're very thrilled to be on today. And thank you, Claus, for all what you have done to ensure the support of this activity today. It's a great honor also to welcome His Excellency Dr. Amin from Dr. Amin Hussein Al-Amiri from the United Arab Emirates. He's the Undersecretary for the Ministry of Health, and he's in charge of the licensing. Great honor, and so happy to see you, and hopefully we'll meet in person, inshallah, soon. Also a great welcome to our dear colleague, Dr. Larry Schwartz, who is the chairman of Radiology at Columbia University here in New York. And lastly, Dr. Al-Fayyad sends his warmest regard and congratulations to C3, and he apologizes for not being able to join from the King Faisal Cancer Center in Saudi Arabia. With this said, I'll start just by a quick introduction. And Claus, I have to admit that the title even of the panel that we're discussing give me a little bit the kind of, nerve me up because we're more kind of used to see people in person and interact, as we heard from Elizabeth a second ago. And so maybe I'll start with you, like tell us, what's the Internet of Things?
There's a couple of different ways of answering it. If I was answering as a technologist, I would say it's simple. You take a bunch of devices, you connect them to the internet. You've got the Internet of Things. So you got the internet and you got things on it. That's the Internet of Things. That's not particularly useful in this context. So perhaps a better answer is that it's not just about the devices. It's not just about the connected things, but it's about what we can do with it in three ways. It's a new channel to interact. It's a different way of staying in touch, interacting with each other, collecting data. It's definitely about digitized, turning everything that we sense into zeros and ones that we can computationally address. And I think personally, it's also about what I call digitalized. It's reimagining how we do things, which kind of touches on what the previous panel talked about, that there are new ways of staying in touch, and it does change care models.
So, Claus, along that line, please tell us a little bit about the great activity that you announced at Memorial in regard to, I'm especially interested in these 7 bits that you have on the platform, and especially the 24/7 patient service and situational awareness that you brought up.
It's a hypothesis, and I think personally it's true, right? That if you look forward a couple of years, we will have the ability to stay in touch with people and do some active interaction 24 hours a day, 7 days a week, and it doesn't have to be in our facilities. What we're looking at with the Internet of Things is a fundamental untethering from any physical property of the ability to monitor people. It's the combination of connected devices and then the fact that these devices are increasingly portable. If you had equipment that was very large and very clunky and that was all you could do, which is sort of how we used to think about monitoring, then you're tied to a building. But if these things are small, even including your own personal devices, then you untether from the physical environment and you can sense where people are and what their, let's say, biometrics look like remotely. The second part is we're increasingly getting full context, multimodal data. Right? It's not just about the simple stuff. We can start sensing even things like physical conditions, mood swings by doing voice pattern analysis. So it's a vastly bigger amount of telemetry data we can get that goes across the traditional physical metrics and sort of extends across different types of data. So it really is multimodal. Comes down to the interpretation. If you're in a facility, you've got your monitoring stations and you've got people looking at things all the time. If you give Internet of Things devices to hundreds, thousands, hundreds of thousands, millions of people, it becomes practically impossible to have someone look at that 24 hours a day, 7 days a week. It's just not possible to have humans look at that. So you need analytics. And it's really a combination of people and analytics that allow us to monitor stuff at scale 24/7. It's interesting because if you look at this sort of competition that has been out there in healthcare between, so who's better at interpreting data? Right? Is it a trained physician or is it an AI/machine learning algorithm? Interestingly, they come out about even. It depends on the field, but it comes out about even. What's profound to me is that inevitably the combination of the two is better than either alone. So I don't think we're talking about replacing physicians and clinicians with artificial intelligence. I think we're talking about an augment. And maybe the analytics can be the first line of filtering that says what are the events we actually want someone to look at and do a good enough job of filtering out these thousands or hundreds of thousands of millions of signals that people have to look at. And finally, and this is where we go to a different kind of care modeling, ties into the previous panel, is all of this is pointless if it isn't part of a new hybrid care model that very deliberately integrates what happens inpatient, outpatient, and in your home and in your environment. So if you go full circle, where we started was, well, having all these smart connected devices gives us new ability to look at the data and insight, and we can do it 24/7. But it's really all about taking care of people in a more holistic fashion across every setting that you may find yourself in. That would be my take on what does the Internet of Things actually mean for healthcare.
Thank you, Claus. And I'll ask you a little bit further because you just brought up about, the value of that data. So tell us a little bit from the institutional perspective, how much of an asset is the data?
I think it's priceless in many ways, right? It's not something you can put a tangible value on. I mean, in some ways, data is what fuels breakthrough innovation. If you take Memorial Sloan Kettering as an example, like we do cancer research, we do cancer education, we do cancer care. If we couldn't, via data and people, bring together these three, we couldn't continue to forge ahead and drive new insight and innovation in the world of cancer. What's interesting is, and again, this is my personal opinion, it's not just the amount of data, it's the ability to put data together longitudinally that actually matters. And that's hard because you can take all these sensing inputs, self-reported outcomes, all the observations for clinicians, but if we don't have the ability to put it together, then we probably can't get the value out of the data that we intended to. So there's a huge data integration problem here. That's tied to how you put data together continuously, longitudinally over time, and say something meaningful about the context in which that data exists.
Two more points I would like to touch on with you before we ask our colleagues as well. Number one is, as we all, and it was brought up already, prevention and detection is a very critical component. And number two is, especially, for example, for us at Sloan Kettering, research is a critical component of our development as well and how we help people all over the world. I would love to hear how does the Internet of Things help in regard to prevention, detection, and same time regard to research?
It's a difficult question to answer just yet because this is a space that's rapidly evolving, but here's at least one take on it. We know that there are other factors than biology that impact the evolution of cancer. Right? We know that there is a component around environment. We know there's a component around how you live. There's certainly a hereditary component, but that goes back to the biology part. I believe that the way the Internet of Things can help is it gives us those other two dimensions. Like beyond the biology, we get the environmental data, we get the data around how people actually live, how they behave. And those three things together gives us a multi-dimensional, multimodal model that I think can drive new insight. You can imagine a world where we can combine the traditional mouse models with some kind of human model that's tied to what's actually going on inside your body, and then you put the environmental digital model around it. And that hybrid model, I believe, will give us a new cycle of insight, and it will allow us to form and prove hypotheses, or disprove them as it may be, on a much faster cycle. Now, can I prove it? No, because nobody's done it yet, right? That's what's next.
Great, that's extremely helpful. Actually, it's a great transition to our colleague, Dr. Schwartz. So Larry, already Klaus said it's difficult, but I'm sure you can handle difficult questions. From your perspective in radiology, and specifically in regard to what Klaus already referred to or hint to AI, tell us a little bit more about Internet of Things in radiology, where it is, where do you think it's going?
Wow, yeah, so I think we could think of radiology and the imaging data really just as one of the many components of the Internet of Things, and Klaus really did touch upon a lot of aspects of imaging that's important. First, the untethering from the physical environment. So our use of imaging in the Internet of Things will be different. How often will a patient actually be coming in, or a healthy person for screening actually be coming into a facility in the future. But I really like to think about it differently. I like to think about how imaging could be more appropriately integrated using other analytics into the healthcare, not only in cancer, but in survivors of cancer, throughout the course of their disease. So there's no doubt that when people think about AI, they naturally think about imaging because of its large presence of data, but I don't actually think about imaging and AI in isolation at all. Yes, we may be able to more easily detect a pulmonary nodule. Yes, we may be more easily able to detect a pancreatic cyst with AI, but what is the meaning of those findings, and how does that integrate with a patient's other healthcare information? Just not to take too much time, but Klaus also mentioned the longitudinal following of patients. And this really is where AI excels, and especially AI excels in imaging. We're all used to seeing patients, and hopefully more and more patients, with serial imaging studies and serial other biomarkers obtained over time. We can ask many questions about this. Are those the appropriate biomarkers, including the imaging study? Have we obtained those imaging studies too frequently or too infrequently? And can we actually trigger some of these sensors that may not be in the homes, such as imaging devices, more appropriately using and integrating the data? The aggregation of all this data actually could help us tremendously in that regard.
Thank you, Larry. Just to help us decipher this a little bit further. So in my basic understanding, an X-ray is an X-ray. It's a picture with, halos of, colors that range in the gray and, a spectrum of black and white. But are you seeing now that same X-ray as being more digital kind of pixels of 0 1s? And how will this be kind of interpreted accordingly for the patient's sake?
So every type of imaging study now is purely digital, and we have to think about that. And I like to say, a pixel is a pixel is a pixel. So we can identify findings. We can, in a more automated fashion, identify findings, but that's not necessarily a good thing, right? What's important is that we put these findings, we understand these pixels in the context of the patient, in the context of their disease. For those clinicians out there, getting rid of the expression clinical correlation is recommended. How many times have we, read that in a radiology report? And that's information that should be available to us, and that's information that we really want to integrate in. And I think what Klaus has been referring to is how we could actually best integrate that in. How could we best come up with analytics to automate that process, to make the clinician a smarter person in terms of integrating, and the patient, quite frankly, smarter in terms of integrating that data.
Along that same line, would it mean that radiology can also become diagnostic, i.e., I will be saving a biopsy for a patient one day?
Ultimately, I don't know if we're going to save a biopsy for the patient, and this gets into some cancer specifics. We may have to combine that with a liquid biopsy, but we could certainly, I believe, help direct the biopsy to the appropriate location. And that's just not as we've done for the past 20 or 30 years. Here's where we have to go and give you guidance. It's actually more to give you insight into the change in these lesions over time, into what the meaning of the change in the lesions over time may be, together with the other biomarkers, to understand that. And even within a lesion, as dealing with large liver masses, these are quite heterogeneous. Where can we obtain the most information? When we look at, the spread of tumors amongst multiple metastases, those metastases may actually be different. And it may be an image that helps you sort out where you need to acquire the most helpful information, the change in the information, for a patient.
Thanks, Larry. Before I carry on with His Excellency Dr. Al-Amiri, I have a question for you because I'm going to pass it on also to Dr. Amin. How do you see the Internet of Things helping or enhancing the potential for radiology across borders? Like, there's become a global activity that you are in New York, the patient is in Dubai. Like, how do you see this going on?
Well, radiology was probably one of the first disciplines to be able to be practiced, remotely, the so-called teleradiology. The urban myth of many radiologists living, globally and reporting, for patients in a country, that certainly does take place. But again, it's really the Internet of Things, or, we don't have to use that expression. It's the coalescence of appropriate data to allow us to interpret the information on an image, and it's to allow the clinicians to interpret the findings of the radiologist in a more quantitative, computational way, which will really change things and, break down any borders that do exist.
Great, thank you so much, Larry. I'll pass it on to His Excellency Dr. Amiri. So, I would love to hear, you heard what Claus and Larry have to kind of, developed or they could offer. I would like to see on a potential receptive end across the globe, how do you see this Internet of Things helping our dear patients, for example, in the UAE?
Thank you very much. First of all, it's my absolute pleasure to join you here today in C3. I prepared a short presentation. In fact, I wanted, as a response to your question, if you'll allow me to share this presentation with you.
Sure, by all means. Sam, you can please help. Oh, perfect. Thank you.
Is the presentation clear to all of you?
Yes, it is, Dr. Amin.
Oh, excellent. In fact, as Dr. Lawrence was saying, the teleradiology was among the medical discipline which was started to help in taking a consultation by distance from between different hospitals. And I do remember we were the first country in implementing the telemedicine and cardiovascular disease, and mainly the cardiology unit between Al-Mafraq Hospital and Mayo Clinic with Professor Gora. I don't know if he's still practicing or not. And that was in year 1994, I believe. In fact, the most important thing here to understand that where the human beings, their ideas, innovations, dreams, and connections are the capital of the future. This is the say of His Highness Sheikh Mohammed bin Rashid Al Maktoum, who is the Vice President, Prime Minister, ruler of Dubai. And I'm quite sure you know that where the great mind goes, the great things could happen at those places. And here, with our leadership, we have almost close to 200 nationalities from different countries in the world globally that are living in peace in our country, and with their help, with their minds, with their ideas, with their innovations, now we are seeking to reach to Mars. And I'm quite sure that a month back you heard that what the United Arab Emirates started to plan for. Now, as you were talking about innovations and how this could be adopted in healthcare sector, I will try to share with you some of the examples of, if I will go to talk about the telemedicine, which this was very much, increased in terms of the healthcare delivery in United Arab Emirates, and not even since, as I said, 1994, but mainly during the COVID-19 pandemic situation, which we tried to keep the patients at home and safely away from the hospitals and the clinics. Telemedicine was one of the major part of our main practice. Next is the blockchain. We had a smart application called Hayat, which we encourage the organ transplant program. Hayat is that each single donor can log in through his smart mobile and submit his request or his aim to donate his organs in just 3 steps, in a couple of 2 or 3 minutes. There are a lot of innovations which was implemented, like a 3D printing and printing some of the PPEs at the level of United Arab Emirates, the research and development by using the stem cells of different COVID-19 positive patients and using their own autologous stem cells to put it put it back to the patients and to try to cure their disease. And by the using of the nebulizers, we were able to use their own stem cells. And this was, the new technique in UAE, which was, registered locally as a patency. Despite that, robotic surgery, which is very much highly demanded in United Arab Emirates and in different hospitals, mainly like Cleveland Hospital, Abu Dhabi Cleveland Hospital, Al-Qasimi Hospital, Fujairah Hospital, City Hospital in Dubai, which is one of the private hospitals. Despite that, the connection between the academic side and the healthcare sector, which was the first at the history of UAE, I'm quite sure at the region, that we were able to do a full genome sequencing of COVID-19 virus, and this was performed and done at Mohammed bin Rashid University Hospital. Despite that, I talk about the stem cells. On the other hand, usage of the plasma of the COVID-19 positive as an antibodies extracting from the positive patients with COVID-19 to be re-injected autologously through the autologous system back to his own patient. 2 weeks back, we were the first country to register the vaccine against the COVID-19 virus with Sinovac, which is the Chinese company, and we accomplished 56,000 of healthy volunteers, which they accepted to take the vaccines on the clinical trial phase 3, and the vaccine was now registered to be used on the emergency use for the front line, which is the health professionals. Despite that, any of the innovations can't be well implemented, and you cannot improve your healthcare services unless if you have the infrastructure, and on the top of the infrastructure is not only the airports, the seaports, and the free zone, but the legislation and the laws which it support you to implement the clinical trial, supports the R&D, supports the implementation of the new technologies. For last 4 years, since 2017 until now, we had 32 new laws which was launched at the level of United Arab Emirates. Those sort of improvements leaded that UAE to become one of the leading countries worldwide, which we have the highest number of the hospitals accredited by or through the JCI, which is Joint Commission International, the highest outside United States of America, and almost 88% of our hospitals, governmental and the private, it's almost accredited by the JCI, and this also led the enrollment of the unique most eminent international hospitals to come and join us, like Cleveland, Abu Dhabi, like the Seoul National University Hospital, which they are running Sheikh Khalifa Hospital in Ras Al Khaimah, and we have the Sheikh Khalifa Medical City in Ajman by the Global Health from Sweden. We have affiliation between American Hospital and Mayo Clinic in Dubai, and we have Al Qasimi Hospital, which their emergency is being run by Health Canada. This is a sort of examples which UAE is a leading, and not only in the healthcare sector, but also in the pharma industry. And this is one of the examples which was released by the IQVIA, or I'm sorry, by the PwC, that UAE is the leading in hosting the most international pharma industry. In 2014, we had 47 scientific offices representing international companies. Now we have 83. They are covering 41 countries worldwide, and we have out of them 25 of them their logistic hub to cover 41 countries that are based in Dubai. And on the left side, this is an example that we have 19 existing factories producing more than 1,500 different SKUs, and we have 17,000 medicines registered here in United Arab Emirates, and we are the first country at the level of Middle East to register the biosimilars and supporting the biosimilar medicine in UAE. And also, since not only 2016 but 2013, to have an MOUs between the local factories and international factories to introduce the innovative medicine. If you will ask those companies why you have been selected UAE to be as international land for establishment, or your scientific office, or your logistic hub, the three main reply that they will reply you, and this is again done by the PwC, that because of the lifestyle and the support from the government, open door policy, and also it's very common that you can do your business with 100% ownership without having anyone from the Emirates to be with you. You as a foreigner company, you can have 100% ownership of your company, and also the regulations which it supports the investment of your company here in United Arab Emirates. Before ending my presentation, I would like to share this slide with you. This is an example that how we are into innovations and into introducing the new technologies. This is a part of it, which is UAE is one of the leading countries worldwide in terms of the most accelerated drug registration policy, that as soon as the drug is being approved by FDA in the state, or EMA in Europe, is being registered in UAE, and this is for the sake of the patient, that they can have an access to most innovative medicine. Number two, supporting the medical tourism. Number three, supporting the international hospitals to introduce new technologies and new treatments for their patients, because the drugs are available, even the genetic drugs. And in terms of the number on the main slide, it shows you that we are one of the countries which we have the highest number of the drugs approved, internationally registered with us. I'm quite sure that you know that if you have strong leaders, you will be able to succeed and support your countries. And whenever I say you, it means whoever lives in this beautiful country, the United Arab Emirates. That doesn't necessarily need you to be Emirati, but you as a health professional working in Cleveland, Abu Dhabi, or working in Mayo Clinic here with us, with American Hospital, or in Sheikh Khalifa from Seoul National University Hospitals, because all together we will work together as one team for the sake of the communities and the rest of the communities, and to make sure that we will be so strong in introducing the new technologies and competing the rest of the countries, and to be number one in terms of the competitiveness. This is my end of my presentation, and I think I was able to cover partially your question, Dr. Ghassan.
Thank you so much, Dr. Amir. First, congratulations to the UAE and impressive work, and thank you and congratulations to you on great efforts as well. I would love to ask you a question, and you touched on, and also Claus brought up as well, in regard to the next generation sequencing. And understandably, this is, of course, a commitment that we have, as you kindly suggested, for all humanity, and understandably, a good analysis of what the population of different parts of the world or countries will be needed. How much of that effort is happening in regard to the Emiratis in your area?
In fact, as I said, we have close to 200 nationalities here. We, as Emiratis, we stands for total 20% of the total population. But the good thing that the Mohammed bin Rashid University started to do the sequencing from different ethnic people at the level of the country, and they are also trying to affiliate with some of the hospitals abroad, like in France and United States of America, and to make sure that they will be able to reach to the sequences which it helps the rest of the countries in the world, not even just to keep our the outcome of our research and development for our own, but we have to share it internationally. And therefore, we are doing the same with, we have Sheikh Hamdan bin Rashid Medical Award, which they have a part of their award is the Arab genome. And I don't know if Dr. Ghassan, you heard of Arab genome, that they are trying also to do a sort of sequences of different hereditary diseases that they have been discovered so far, 73 different hereditary diseases, was very common in UAE through different ethnic people which are living here, but was not being published and was unknown worldwide, which they are trying to share this with some of the university hospitals abroad and some of the research centers. And therefore, we are so keen in sharing those data, those data with others that everyone could benefit, and mainly the pharma industry in terms of the producing of different type of drugs.
Thank you so much, Dr. Very impressive work. Along that line, actually, a critical question that you kind of suggested here, I'll go back to Claus. So we all are talking about the Internet of Things and the asset of data, as you also suggested. Claus, the question is, who owns that data?
Well, it depends on who you ask. If you look at it through the lens of privacy legislation, then clearly the patient owns the data. But why don't we take apart sort of the different dimensions of looking at data in the first place? That might be helpful in order to answer the question. So the first thing to realize with the Internet of Things is you can't save all the data. It's not possible. So there's a lot of data coming from millions of billions of devices, and it's coming in real time. So the first order of business is to filter what data you even want to store. So the first realization is you can't store everything. So what we're really talking about is who owns, have access rights, can use, etc., the data that we do store. Because the data we didn't store is kind of gone. Right? It came out of the devices and it's gone. Then if you look at the data we do store, there's three parts of the problem. The one part to the problem is how do we do the data engineering piece? It's not an ownership question. There's a lot of heavy lifting in just putting the data together. We basically talked about already that it's not enough to have it. It's a matter of putting it in context. Dr. Schwartz said, and I completely agree with that, it's about the context. The context is really what unlocks the value. If you can't follow a specific condition over time and space, then you won't be able to reason about the data. That's not actually an ownership question. Right? So in a lot of cases, we get it confused because we say that we have to combine the discussion of who owns it with the question of who does the data engineering. I don't actually think that's correct. You don't want clinicians to have to worry about how to put the data together. That's the job of data engineers. So that's the first part. We have to put it together the right way. It's an engineering problem, and we haven't used it for anything yet. We just need to put it in a place that's actually protected so people can't use it. The second question is attribution. Some data doesn't have attribution. Other data was created through the hard labor of individuals. And we need to make sure that we can track the lineage of the data and actually also make sure that we're aware of the attribution. And finally, you get to the question that says, what is appropriate use? And appropriate use is something we're pretty much used to handling in the healthcare industry. We have various processes, committees, etc., that reason about appropriate use. What we have to do is put that on top of the hopefully solidified, well-integrated data set that we have created. If you can address all four of these, the filtering, the engineering, the attribution and lineage, and put controls on top of this integrated data asset you have hopefully created, now you can talk about ownership. But ownership to the lens of who gets to say what data can be used for. And where I started is ultimately the data, at least in your home setting, is yours, unless you give consent to use it for other things. Right? So the question of consent and what I agreed to becomes fundamental to driving a hybrid care model that goes across these multiple settings. If you're in a hospital, it's a little simpler because you chose voluntarily to be in the hospital. If you're in your home, by definition, it's yours until you say otherwise.
Ghassan, can I add something here, if you don't mind?
Please do, of course. Please, Dr. Amin, please.
In fact, let me talk about the UA experience. In 2019, we had a new law for data protection. And as per our law, the data is being protected by law under the control of the federal government, the Ministry of Health and Prevention, from all the patients at the entire country. Either they go and visit the private or the governmental hospital, but mainly as per the law, data, it's the right of, each single patient. It's their own, I can say, a right to have it, unless if you have the consent from them that they allow you to use those data, either limitedly or the full data. But I think at the time being, it's very important for each single country that if they have the ability to do data engineering and to get use of those data after taking the approval or a consent from the patients, the patients, and mainly with NCDs, we will be able to really reduce the economical burden on the governments and reduce even or put the guidelines and the precautionary steps and the tools that how we will be able to prevent the cardiovascular disease and to spread the proper lifestyle among the community. Data could help a lot. Data engineering is very important, but it's here. The point is that how this could be handled by each single government and how this could be used by proper data engineering.
Thank you so much, Amin, and thank you, Claus, as well. Larry, just a different perspective as well, from the radiology standpoint, and not from the legal ownership part, but nonetheless, a functional one, an operational one. What does patient own? Is it going to be like just a CD with a set of pictures? Or is it going to be a USB with some pieces of data that has to be dismantled or put together by a radiologist?
Well, I think the same aspects that Claus mentioned certainly hold true for the imaging data as well. The advantage of it, unlike pathology or tissue, is that since it is digital, it could be easily reproduced, with 100% fidelity. Again, the key, as was mentioned, is how that data is engineered, how that data is analyzed, which is a tremendous amount of work. I will just bring up one other point. Independent of individual consenting and obviously patient rights and things like that. With AI, we have the potential by sharing this data to really benefit society and to understand how, by aggregating this data, by understanding diseases in, the imaging world. I just think about, screening with mammography, lung cancer screening, virtual colonoscopy screening, and, how we can make our systems, smarter, identify cancers earlier, prevent false positives, which is probably the single largest challenge that we have globally in terms of getting people to be screened, and, how valuable to society, this data becomes. So however we address it, we have to figure out how to address it. Because, putting this together either for precision medicine on a small scale or for, societal, global, screening, is critical.
Thank you, Larry. Very much appreciated. we have plenty of time for questions, and believe it or not, they're already flooding. So by all means, I first would like to again thanks Klaus, Amin, and Larry for their very valuable comments. And with this, we'll take the first question, which AI from the perspective of computer hours that of work, and the what could it accomplish in microseconds compared to the hours. A question probably more about efficiency. Klaus, how do you read it?
If efficiency is tied to computational power, perhaps more interestingly is effectiveness. If you take AI and machine learning, throwing an algorithm at data is easy. That's become relatively standardized, and the spirit of the question is this is correct, right? That you can do in seconds and minutes what would have taken days or weeks or months before if you have enough computational power. What we're also seeing is that it's very difficult to get a good data set to throw a machine learning algorithm after. Either because your data set isn't complete, or in some cases because your data set is biased. I'm aware of at least one case where a team was trying to train a machine learning AI-based algorithm to recognize specific medical conditions on images of all things. What they ended up training their algorithm for was to recognize images from a particular piece of equipment that happened to have a higher fidelity of the actual image than the comparable equipment. So obviously you got better diagnostic data out of the better equipment. That wasn't what they thought. So sometimes you get surprised. If you're not very careful about what data you give to the algorithm, you might get the efficiency, you may not get the effectiveness, which is why actually doing well on machine learning AI-based augment is what I would say is the game we have to play. Is something that requires careful deliberation across clinical staff and technology staff.
Thank you, Klaus. And by the way, for all our dear audience, if you have any questions, by all means, you can raise your hand, or if it's a little bit complex for it, just please interrupt. We're happy to take your question. And while we're doing this and you're thinking about your questions, one more question, which I have to admit, this is really quite fascinating. Question is about Liberia in controlling COVID-19. They did depend on their Ebola technical and computers, and they did extremely well. I'm not sure if any of our panelists have question, or at the same time we have Dr. Abou-Alfa. Elizabeth, you're still on. Dr. Hashmi, Maliha, you're still on. Maybe you can help us with that question. If anybody has any experience with the Liberia, with the COVID-19 and the use of AI, and how was this experience for the current pandemic that we're dealing with? Elizabeth or Maliha, I think you're both muted. I don't know if you would like to help us with an answer.
Hi, Ghassan. I haven't been intimately involved in that Ebola response, but there are a lot of parallels in terms of what you need to do for contact tracing for COVID-19 as well as Ebola, just in terms of communicability. Obviously, the modes of transmission are somewhat different, but having that infrastructure in place is certainly a big advantage to Liberia.
Thank you, Elizabeth. By all means, we're happy to hear about this positive news as well. And I think there is one with raised hand. Please go ahead. Whoever kindly asked a question or raised their hand, please, you can go ahead, or maybe you can make sure you're unmute.
I think the hand has been raised for a while, so I don't know whether it's still intended.
No worries at all. Actually, we have one more question anyway. So, Dr. Amin, the question for you in regard to another perspective is education. and how can we ensure that our dear colleagues, wherever they are, for example, in the UAE, are kind of evolving in making sure that the best practices are being discussed. We learn from them, they learn from us. What do you think the current Internet of Things can help in regard to education?
I think this is something which has been, which has been taken care of very well by the academic side, mainly the 5 Faculty of Medicine and Health Sciences, which we have in UAE, that they started since I can say March 2020, that to convert their educational program to the distance learning and the usage of the internet facilities to reach out all their students perfectly and to make sure that they will be able to I can say, send their proper messages to them, vice versa. Despite that, in fact, many of the universities tried to use the AI in learning about the knowledge of their students, mainly whom they are studying at Faculty of Medicine and Health Sciences, with their experience practically while they were at the hospital, volunteering with us as the students, and they are with our hospitals and they are under the control of our hospitals, and they were not able to join the university, and the universities were in contact with them through the internet facilities or usage of the new AI, I can say, technology to reach them with the rich knowledges and experiences, and combining both the main practice and the theoretical one through their university. This is one example which was taken place in the United Arab Emirates, but my personal thinking is that the internet could lead the educational program widely and could support very much. And I'm quite sure that so far none of the schools or universities here in UAE is physically in function, but they are in connection with all the students, with their either schools, primary schools, high schools, and the rest, and the universities through the internet facilities with their teachers or with their universities. And therefore, I think this could be the future, even after the COVID-19 pandemic situation. A part of this is what we are planning now. A part of the educational program to be physically, and other part could be done through the internet. We called it Al-Ta'lim al-Hajin, which is in English could stand for the joint procurement of educational program, or between the both.
Well, thank you very much. I can imagine that Ta'lim al-Hajin is, of course, as you kindly suggested, is the multidisciplinary perspective as well can come into play. And you're absolutely right. This is nice to hear that you already are on board in that regard. Larry, another question just came up in regard to the AI and the perspective that, after all, AI was able to beat all chess players and all computers. Do you think it's going to read the CAT scans better?
Well, I think it's going to help us to read the CAT scans better and to interpret holistically, the data better. So, Claus had said it early on. A lot of people were, I like to quote Mark Twain with this regard. He once wrote, or he said, "The reports of my death are greatly exaggerated." I think that, I think 20 or 30 years, 20 plus years into the practice of medicine, I'd still be, visually trying to identify pulmonary nodules. and not using a computer for that? No. So of course, AI is going to be able to help us with certain tasks. I think what it's going to be able to most help us with is to aggregate the data together, but then we will have to, of course, interpret that appropriately.
Great, thanks.
Ghassan, I think one way of thinking about it, this really is the different. I've been spending a fair amount of time thinking about this. Is you think about chess, it's very, very complex because it has a finite set of well-understood rules and a deterministic outcome. You either win or you lose. If you look at healthcare, medicine, human bodies, we don't understand all the rules yet. And because we don't understand all the rules yet, there's a limit to how smart we can make the kinds of computational capabilities that we try to help people. There is such a thing as intuition. You can approximate intuition, and it can look like intuition with an AI and machine learning algorithm, but it really isn't intuition in the human sense. It is still a computational, though at a very large scale, approach to a problem. And if we don't understand all the rules and we don't have a finite set of possible outcomes, you can't actually get to the perfect solution. So anybody who's looking to AI and machine learning for the perfect solution for human medicine, they're going to look in vain. It's never going to happen.
Well, thanks so much.
Klaus, can I share with you?
Yeah, please.
Klaus, can I share with you one of our experience in using of the AI with the chest images? You know that any of the foreign people comes to our country, they have to sit for a certain number of the tests like HIV/AIDS, hepatitis B, and also we do the chest X-ray for making sure that he's not infected with tuberculosis, which is the TB. There were two companies which they introduced a new technology, and one of them was implemented in UAE, in which it was approved by the WHO and gave the accuracy and sensitivity close to 95%. That by using AI, I mean, we were able to let the technology read those images and find out if it's positive or negative, positive TB or negative TB. And this was, I mean, implemented in UAE since last January, since we had an Arab Health. I'm quite sure, Ghassan, you know the Arab Health exhibition, which is one of, or the second biggest worldwide after Düsseldorf. This was implemented in UAE, and it's giving a very high result, almost close to 95%. The AI technology on behalf of the radiologist reads the chest X-ray and gives us the result, the accuracy, almost 95, 96%. It helped us a lot, saving time, saving money, and also connecting through those health centers to the main hospitals, that all the data could be saved for that patient for the near future, because he comes for the renewal of the residency every 2 years. He has to be retested. I mean, it worked very much with us. Recently, there is a company called G42, belongs to Abu Dhabi government, also implemented the usage of AI for testing of the COVID-19 for COVID-19 virus by the one drop of blood, and they use the AI in combining the electronic microscope with the electronic cameras, and they can define the shape of the virus by one drop of the blood in just 5 minutes. They can give you the result, and the accuracy and sensitivity was almost 94, 95%. And this has been implemented at the level of UAE, and they have been taking the patency for it so widely in UAE. I think usage of AI is the future at the field of medicine.
Thanks so much, Dr. Amin. Actually, and thanks again for Dr. Robilotti, and thanks for what you just sent me. Beautiful article, which happy to share. We can work on that later, but nonetheless, it's from the MIT Technology Review on the Ebola experience and the COVID-19 experience in Liberia. And it's quite impressive that at the end of the day, and I think, Elizabeth, very smart that you sent this, because ultimately, this is a country that had literally at the first of the Ebola, like one ventilator. And at the moment, with the perception that the COVID-19 is a hoax, they kind of, felt that the most important is education, something that we already all spoke about. And if anything, they really want to make sure that the basic principles, as we already heard them through the morning about, you know, the hand washing, the distancing, the masks are important preventive activities. And it seems they did a beautiful job in that regard. But thanks again, Elizabeth, for sharing this. With this said, we have literally 3 minutes, and I would love to take closing remarks, and we'll start with Claus.
To ask me first. My closing remark is going to be this. We're only now beginning to understand the potential of what happens when we combine the Internet of Things, big data engineering, and smart algorithms. So we're beginning of a long journey. To me, it's all about how we meet the needs of the whole human and how we get better understanding our entire health journey from even before we get diagnosed with disease all the way through hopefully, you know, cure and a happy, healthy life. To get there, we're going to have to be very judicious about all the things we talked about. And be that the collection of the data, be it the data engineering, be it the consent that goes with it, the controls on how we use it, and ultimately how we mix and match the great people in the healthcare system with emerging and great technology.
Thanks so much, Claus. Larry, your thoughts?
Yeah, so, you know, similarly, there's a lot of work to be done, and there still is, despite AI and the Internet of Things, a limited resource to do that. So I think we have to ask the right questions, provide the right appropriate data to those questions, and I believe we'll succeed in that matter.
Thanks so much, Larry. And I mean, first, congratulations, quite impressive in regard to what you've been achieving in the UAE, and something to be definitely very proud of. And I love very much the perception that you brought up in regard to serving humanity. With this, please, your thoughts.
My thought is that Internet of Things is the future, but it's very important that we have to study it very well, do it precisely, and convert it for the sake of humanity and mainly at the field of medicine. And I'm very much optimistic that there will be a great future of interneting the things and data engineering.
Well, I would like to thank for all our audiences and colleagues who shared this session with us. A special thanks come to Dr. Jensen from Merck Sloan Kettering Cancer Center, our Chief Digital Officer, Dr. Larry Schwartz from the Chairman of Radiology at the University of Columbia University, and our dear colleague, Dr. Amin Al-Amiri, congratulations, the Assistant Secretary of the Ministry of Health in the United Arab Emirates.